قلبي على جمعة الخير هلا، حن قلبي على جمعة الخير هلا، يا هلا ويا هلا ويا هلا ويا هلا، يا هلا ويا هلا ويا.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and welcome to the program. It's a Saturday morning. That means you and I are going to get talking on a whole host of things. We're going to be looking at psychological issues, anxiety and depression. We're also going to talk business and politics with someone from Business Leadership South Africa, and right now we're going to be looking at issues around back pain. Now, it is said that approximately at any given time, approximately 10% of people all around the globe present with lower back pain, and most of them self-diagnose and self-treat, but it reaches a point where they then have to seek medical attention because the self-treatment just ain't working. So of course our first port of call happens to be the physiotherapist, and that's exactly whom we have in the studio this morning with us to talk lower back pain. And do remember, you can call in with questions or comments and do become a part of the conversation. Gives me great pleasure to introduce to you Justine Hunt. She's a physiotherapist and a craniosacral therapist. Good morning, welcome to the program.
Good morning, how are you?
I'm good, thanks. Did I get that right?
Yes, it was perfect.
Oh. Brilliant. Now, lower back pain, again, I need to ask you, the figures, 10% of people around the globe presenting with this condition, lower back pain, on a daily basis.
I would actually think it might be a little bit more, to be honest, because a lot of people don't necessarily tell anyone, but if they start talking about it, or if I meet people at a braai, you know, even if I'm talking to a couple, they'll say, oh no, my back's also sore and my back's been sore. And even her husband will say, but you haven't told me that. Mm-hmm. So it's been quite amazing actually that, you know, that's kind of how, you know, people don't even necessarily talk about it unless it's an opportunity to talk about it.
So we just go on and suffer in silence.
Exactly.
I think next to headaches, lower back pain is the most, is the second most condition that people suffer with from around the globe, and we suffer in silence till, like I said, it becomes so debilitating or so excruciating that we need to seek medical attention. Now, what's the issue around lower back pain? Why is it that so many people present with this condition?
You know, it's today's society, it's the way we're sitting in cars for extended period of time, we're sitting at desks for extended period of time. So functionally, we're not as active as we should be. We're more sedentary, but we're not doing work with good posture. You know, we're sitting in slouched positions. We aren't stabilizing our core stability. We aren't out there exercising, healthily lifting things and doing that kind of work. We're sitting too long. Then we're sitting too long in traffic, and then you're sitting with a poor posture at your desk. So we're getting a lot of repetitive strain injuries, a lot of postural problems, a lot of core stability weakness. So it's becoming a problem in society today. I really think so.
Now, two issues, Justin. I'm thinking when we talk about posture and the time spent sitting either at our desks, in our cars, whatever it is, the type of work we're involved as well. And I should imagine it also is an issue around occupational hazards, the type of work you do, not necessarily only sitting, but the amount of pressure you put on your entire posture.
Definitely.
Is that then saying to us that lower back pain only presents in adulthood? Because young people are very active, they're very mobile, they're involved in sport, but once they reach their adult years and they become more sedentary, or they just develop very bad habits, postural habits, that this is when the problem starts.
I don't really think so, because to be honest, Julie, there's a lot of people, even young children, even teenagers, if they suddenly have a growth spurt, if they're growing very quickly, the membrane grows slower than the vertebra. So then you've got a problem where they start getting tightness in their lower back, and even pelvic problems can come from small, from childhood injuries or falling off jungle gyms, those kind of things. So generally, I would say, you can say generally most of the population might be suffering sort of over 30, but it doesn't exclude young children. There can be all sorts of problems that can affect young children as well.
To kind of, just prevent us from getting to a point where we're going to be plagued by lower back problems in the later years of our lives, is there specific things we ought to be doing in our early years in terms of sport, supplementation, certain types of exercises? And if the answer is yes to that, what would it be?
Definitely yes. It's very important from young age to be aligned. So, some people only see a physio when they've actually got an issue. But I would recommend that even for a child, a small child, when I work with the cranial, work with newborn babies, if they've had a forceps delivery, for example, and the top of the cranium is actually rotated on the first vertebra, that offsets the alignment of the whole vertebra into the pelvis. So that child is predisposed to an injury or predisposed to back pain at a later stage. It just depends on how soon the body feels it can't keep using compensatory patterns to fix that problem. So from young age, it's quite important to maybe just have one session, align, check your alignment of your body. Then definitely nutrition is important as well. Sports, I'm finding a lot of teenagers at the moment, a lot of male teenagers I'm treating are doing a whole lot of one-sided sports, which people don't really seem to think about. They're doing cricket and then they're doing squash and they're doing everything that is only maybe using their dominant hand, bowling, etc. with cricket, and then they're only using the squash racket on the right-hand side, and then they play tennis. So I'm finding that those children that are only doing those one-sided dominant sports, the whole one side of their vertebra, the shoulder girdle into the pelvis and everything is all very strong and over activated, and then the left side is weak. So the pelvis starts to rotate, and then the vertebrae start to rotate, and you start getting a whole compensatory pattern where they start getting knee issues on the one side, and the body is always trying to help, but it goes into compensatory patterns, and then there's more issues that start to happen.
Now, we can't emphasize the importance of sport enough. I mean, we always say sport. It's going to keep the kids off street corners. It's going to give them a very healthy and alternative lifestyle to all of the other social evils out there.
Definitely.
But that too comes at a price, as you've just explained.
Yes. So I think what I would say is if a child is doing a lot of, if they really love their squash or they love their tennis or they love their cricket, try to find a sport that can balance, that's doing bilateral movement. So try to encourage then maybe some swimming or athletics. So they shouldn't only be doing one-sided dominant sports. They should be doing at least one sport that can counteract, or they should be then maybe just doing a maintenance session of biokinetics or physiotherapy once a month or once every 6 weeks, where we can just monitor what's happening or give them exercises to work those muscles that aren't being properly activated during these sports.
Could I come to you with my children, my very sporty children, and say, okay, child number one is, plays golf all of the time. Child number two is involved in soccer. Child number three plays only tennis, and child number four is a swimmer. Would you then be able to work out a plan for them to help compensate for their weaker side, number one? Or do I go to a sports therapist, for example?
Look, I can definitely work with that. And with the cranial work, we treat a huge variety of conditions, which is what I love about it as my specialization from the physio. But it is,
and this is at any age.
At any age,
it could be a toddler up to a much older person.
I've treated 80-year-olds, 85-year-olds. I've treated newborn babies that are 2 hours old. We can work with the system. We work with what's happening. So the system we're talking about is the whole craniosacral system, which is the cranial plates, which is forming the skull, the vertebra, the dural membrane on the inside of the vertebra, and the spinal cord, and the tailbone and the pelvis, and everything that's happening in between. The nervous system obviously still extends to our fingertips and to our toes, but we work with the alignment of that whole system and what's happening with the system. And it's affected not only by physical injuries, but also by stress, emotional stress, or, some people posturally will move into a different physical posture because of emotional stress, or if they're scared, so we work on such a wide level of not only physical injuries, but we incorporate everything that's happening. We look at the human being as a holistic whole. One child might be, doing their swimming, but because of the birth that they had, they struggle with repetitive strain injuries of their shoulders. The child that's doing the cricket has maybe got a pelvic rotation issue because they fell off the trampoline when they were small, and that's never been corrected, and now they're only doing a one-sided sport, so we need to then balance that and then strengthen their weaker side. So it's very much looking at each person as a unique individual.
And children don't often vocalize what's going on, with them. They've just had their fun hour or two of sport, but they don't normally suggest or vocalize that this is paining or that's paining. They also just sometimes put it down to the activity that they were involved in.
Definitely. And I think a lot of parents also will say, oh, it's a growing pain.
Yeah. True.
They say it's a growing pain, or especially young boys, they run around, they're really busy, and I think parents go, okay, they've just been very busy today, or they fell, and scraped their knee. But sometimes you have to almost ask your child, and it's not that you're asking for things that aren't there, but you can just say, how are you feeling? Close your eyes, be aware of your body. Where does your mind direct you to in your body? Because our bodies and our minds, if we're in tune with ourselves, we can feel what's happening within ourselves.
Now, you spoke about growing pains, and I remember growing up as a child, I always had lots of bodily pains, very especially in my legs, and my mum always fobbed it off and said, oh, it's just growing pains. It was excruciating, and nothing really was ever done about it, but it probably was. I don't know, is there such a thing as growing pains?
Yes, there actually is, especially in the legs and especially in the tibia, because these bones grow quite quickly, and the connective tissue that's connecting the muscle to the actual shin bone, to the front of the shin bone, actually does for lack of a better word, slightly tear when it's growing, when that bone is growing fast. So there definitely is such a thing as growing pains, but it's monitoring that and then looking at supplementation. Perhaps the nutrition isn't very good. Maybe you need to increase your magnesium levels if you're having a lot of muscle spasms as a small child, and all of that kind of thing. So that definitely is where the nutrition comes into it.
And is physiotherapy recommended in a situation like that? An 8-year-old or a 10-year-old child, or possibly even a younger child?
Because there might be, it's good to assess, it's very good to assess. It might be that I can do an assessment, I don't find too much wrong apart from, okay, this is growing pains, let's monitor their nutrition, let's check how they're doing. But a lot of the time we find if especially the growing pains are one-sided, then there is a structural alignment issue.
All right, we need to take an ad break, but I've also just been told we've got a caller. We're going to pick up on these issues and much more. And the good news is that, unfortunately, our second guest is unable to join us, so we have more time with our lovely guest, and we'll also be spending more time with the Dr. Colinda Linder, the psychologist who's going to come in and talk about anxiety and depression. But to our first caller, welcome to the program. Assalamu alaikum to you. Okay, the caller is still sketching out her issue with the producer. So let's take an ad break. When we get back, we'll take the caller. Welcome back. We're talking to Justin Hunt. She is a physiotherapist and a craniosacral therapist. You have heard her alluding to that modality of her work, and we're going to go into it much deeper in a little while. But right now we're talking lower back pain, and we're also talking growing pains. Have you ever experienced that? How did you deal with it? And we do have the specialist in studio with us, so if you have any questions or comments, we are happy to take your calls. We were talking growing pains just before we went for the ad break.
Yes.
Would physiotherapy be an option as far as growing pains are concerned?
Definitely, because we can help to stretch out the tendons, the ligaments. A lot of the time, everything's growing too fast. So that's why often people have growing pain and they might just tolerate it and live with it for 2 or 3 months, and then it'll ease off again. But during that period, there's things that we can do to facilitate. We can do deep tissue work. We can help to stretch out the connective tissue, the fascia, release spasm in the muscles. and help, alleviate the pain, we can definitely try and reduce the pain.
And that's not suggesting that later on in life the person's going to have problems with their legs.
No. It not necessarily. It might just be that they're growing quite quickly. I know when I was a teenager, I suddenly shot up. Between 11 and 13, I think I grew about, nearly 15, 20 centimeters. So I was having that sensation of growing pains, but it resolved itself, and I haven't had any issues since then. So I think it's about, especially if nutrition is taken into account, any physiotherapist will also be looking at nutrition and all of that support as well.
How important is calcium in the diet of a growing child? Obviously to address issues around growing pains, but also to ensure strong, healthy bones.
Exactly. No, that's exactly it. I mean, you need strong, healthy bones. You need good bone density, not only as a child, but the bone density you develop as a child stays with you into adulthood, and that's extremely important, So I would say nutrition is a vital, important part of our body. It's an important part of, what we put in is who we are. Everyone always says that, so it's definitely a big part of that as well.
Let's get back to the heart of the matter, lower back pain. Obviously, as we spoke in the intro, that it's self-diagnosed, self-treated, till it reaches a point of, so excruciating that you take yourself off to a physiotherapist or a medical practitioner. What is it, and how much time does one need to spend with the physio to, try and sort out the problem, number one? And if you're presenting with lower back pain on a regular basis, that surely indicates that there's something more seriously wrong here. What other investigation needs to be done on this patient?
So the physio will take a full history from the client to find out where we think the problem's coming from, whether we think it's posture at work, inadequate seating at work, the computer's too high. So all of that, those kind of problems that need to be addressed. Or if it's mattresses at home, the way you're picking things up, the way you're lifting things, your core stability, are you doing any other exercise? So we often try and find out all of that from the client as well. We do also ask about the type of pain and when the pain is happening. Is it only at night? So there's something we call red flags, and those red flags can start to show us when we think that we now need to refer on either to an orthopedic surgeon or a specialist, because there are certain, very seldom, but there are specific things that will be highlighted to us where we need to follow through. Just for example, there was a teenage child that I actually treated her post-operatively. She had gone to her GP a number of times complaining of back pain. She was only 13, it was quite unusual, and it was in a specific area of her back, and she actually had a spinal tumor.
Sure.
So, not that that's very common, but when all physios are trained to know, we're medically trained to know, when there's specific things that are highlighting to us that we're concerned, we will refer to a specialist. We will ask for x-rays and an MRI scan to assess what's happening, exactly what's happening.
I want to ask about period pains, which is very, very common in young girls, and how that can be treated via physiotherapist, and also mattresses and pillows. How important is that as far as back pain is concerned? People often say it must be the terrible mattress I'm sleeping on. People also say that perhaps you need to put a board under your mattress, or perhaps the best place to get a decent night's sleep is on the floor.
I think the sleeping is a huge thing, because obviously some people sleep shorter hours, but most of us are in bed for at least 8 hours a night. And that's the time the body's resting. That's the time the body is rejuvenating and healing from whatever we were doing during the day. So it is very important that we sleep well, that we have a good posture while we're sleeping. Some people sleep in very strange positions. I know it's sad for some of the viewers to hear me say this, but I've never condoned people sleeping on their stomach, because you'll end up sleeping on your stomach and rotating your head to the one side or the other. And if you're stuck like that for 8 hours, it's not healthy, you know what I mean, to put that strain on your neck and your back.
When the physios asked me, how do you sleep? Do you sleep on your side or your back or whatever? I don't know, I'm fast asleep.
Look, I think a lot of people move around, which is also fine. Movement is good, because innately while we're fast asleep and we move, our body is feeling we call them proprioceptors, which are basically nerve endings that feel too much pressure on a specific part of the body. So that will activate, while you're sleeping, it will activate your mind and your brain to facilitate a movement, to roll over or to move, to take that pressure off that area, which is improving your blood supply and looking after your body. Our body is innately intelligent that it can look after itself. But when you speak to some people that know they go to sleep on their stomach with their head turned to the right and they wake up in exactly the same position, then we've got a problem, because that whole membrane around the spinal cord and the brain, which lies on the inside of the vertebra, if that's twisted and it's stuck in that position for 8 hours, that's not ideal. You know what I mean? If you were sitting at your computer in that position for 8 hours, you'd also be feeling excruciating pain.
And yet, I don't know if it's changed since I've had my babies, but I remember that I was told to put baby on his tummy with his head to the side.
You know why that is? A lot of the time, it's a pressure on the abdomen helps to alleviate colic.
Okay.
So I think that's where it started. People were saying push the baby on the tummy and if the head's on the side, then, if something comes up, a little bit of, milk comes back up, reflux, then they'll be okay. But these days, that's not something we advise. We advise side sleeping, right, and we advise alternate side sleeping.
Okay, so let's get back to the mattress and the pillows.
Yes.
How important is it, how would I know that I'm investing in the top of the range mattress and it's going to work for me?
Look, I think the thing is not necessarily about the expense, but it's about what would suit you. So if your neck is in, we've got that natural posture of the spine. So the lumbar spine is in a lordosis, the thoracic spine is what we call a kyphosis, and then the neck, the cervical spine is back into a slight lordosis. So the main thing is that posture needs to be addressed or held within your sleeping pattern. If you are struggling and you've got sort of over-tucked in chin posture, for example, and your cervical spine becomes actually flattened or even kyphotic, which it's not supposed to be, then I would even advise that you need a higher pillow to actually address that issue, to actually change that issue. So it's not necessarily about we all go out and spend an absolute fortune on the highest, top end, but it's that you're addressing the issue that you have with your pillows and with your mattress, if that makes sense.
People often complain about waking up with headaches. Is it the pillows they're using?
It might be.
Do they need to change their pillows?
It might be the pillows. It might be that they're too high up. If you're sleeping on your side, for example, I hope I don't fiddle with the mic too much now, but if you're sleeping on your side and you're too high on your pillows and you're pushing your head into this position, it's going to affect the whole fascia and the connective tissue and the blood supply of this side of the neck into the brain. And then that might be where you're actually waking up with a slight headache. A lot of the population are also magnesium deficient. Mm-hmm. So that links to insomnia, it links to headaches, it leads to a muscle spasm. So that's where you need to look at the whole body holistically. What is my nutrition like? What am I sleeping on? And what is my posture? And what does my posture require from my sleeping? So a physio can direct you in that. They can say, no, you're not actually an ideal candidate for 2 pillows. You're actually an ideal candidate for 1 pillow. But once we've assessed your spine and we've assessed your posture, we can recommend that.
And as a physio, I could come to you if I'm suffering from intermittent headaches as well.
Yes, definitely.
Because it obviously is probably, in most cases, it could be the way I'm sleeping or the type of pillows or too many or too few pillows that I'm using when I sleep.
Definitely. And posture during the day. We've, with technology, the technology today is that everyone's working too many hours on computers, generally in the population, except for me. I'm working on human bodies. But a lot of the time you get home from work, you haven't finished an assignment for work, and then you'll kind of just put the computer onto a low coffee table, and then you'll be sitting there like this working on your computer, and it's really not ideal for your body. So I can only suggest that we really need to look holistically at how we are, what we're doing most of the time during the day, what we're eating, and then how we're sleeping. Okay,
one more question before we go to our next ad break. You find often people sitting up in bed against the headboard with their laptops in front of them.
Yes.
Is that a healthy posture? Is that going to do them any harm?
Well, especially if you have your laptop on your lap,
yeah,
and you're kind of leaning against pillows and you'll end up being slumped, that's definitely not an ideal posture.
Okay, let's go for an ad break, and when we come back, we're going to continue talking to our guest, Justine Hunt. She is a physiotherapist and a craniosacral therapist as well. We're going to focus on babies and cranio issues when we get back. And do remember, lines are open, so you can become a part of this conversation. Welcome back. We're talking to Justine Hunt. She is a physiotherapist and a craniosacral therapist as well. We're going to start focusing and unpacking what exactly does a craniosacral therapist do, but let's just wrap up on lower back pain, how to treat it, what's the best methodology to get you going for good, hopefully, without lower back pain. Tracy and Justin, lower back pain we know is very common, the second most commonest affliction as far as people are as far as we're concerned all around the world. How do we treat it best in terms of physio? How often do you go for physio? And then when you do present with possibly sciatic nerve issues, does that indicate a bigger problem? I've also heard therapists asking their patients, are you getting feelings of pins and needles? What are they looking for if you're presenting with a sensation of pins and needles?
Okay, so there's what we call nerve referral pains. So they can be in the form of pins and needles, numbness, or very sharp burning pains. So that means that a nerve is being pinched. So it can happen higher up in the neck as well, and then you can have the same symptoms down your hand,
numbness,
which is
or pins and
needles, or very sharp burning sensations. So that will be working then with the brachial plexus, which is the nerve supply that comes down into the arm. The sciatic nerve is the nerve that comes from the base of the pelvis through the buttock and into the leg and down to the feet. So that is the big nerve going down the leg, and the brachial plexus is the nerves. Well, there's three different nerves of the brachial plexus that supply the arm. So what we're looking for there is nerve referral, which means that the nerve is being pinched, or it is being compressed through major muscle spasm and fascial restriction, which is connective tissue. Fascia is connective tissue that surrounds arteries, nerves, muscles. We've even got a layer that surrounds the different organs, which is called a different fascia, but basically it's a layer of thick connective tissue. And if that is very tight and restricted due to long-term postural issues, that can then cause that nerve to be compressed where it's passing in and between muscles, and that can then cause these nerve referral pains.
Can it be fixed through physiotherapy and perhaps some pain relievers, muscle relaxants, etc.?
Yes. So some people look, if in the beginning phase, the physio might suggest, depending on how severe your symptoms are, some anti-inflammatories. You even get your natural anti-inflammatories like your arnica gels, your arnica tablets, and you also get, like the tissue salt number 4 is also a natural anti-inflammatory. So, we obviously don't prescribe medication, but we can just suggest that you speak to your doctor or your GP about your pain management if it needs to be through medication.
And collars, sorry for the interruption, collars and, these corset-like contraptions that people normally wear when they're in severe pain for lower back pain. Do you recommend that? Does it make any difference?
That's quite a tricky thing, Julie, because they're necessary in certain conditions where there is severe problems, where there's actually severe instability of the vertebra, or that if it's a slip disc, we call, then we talk about a disc prolapse. So in severe cases, it actually just creates a physical support system for the body, an external support system for the body. But long-term use of that is that it encourages your body to not do the work itself. So then you stop activating your core stability, or you start losing your neck range of movement because you've been wearing a collar for too long. So I would say that under certain very specific conditions, the physiotherapist together with the specialist would probably recommend that to create stability, especially when there's been a severe whiplash injury or something like that, where the longitudinal ligaments on either side of the spine have possibly been torn. Then we need to give that external support while that's healing. But the long-term use of them, especially without having or not being monitored by a physiotherapist or a doctor, you will be doing injustice to your own body, because your body will become too used to that support and you won't be activating your core stabilizing muscles, and you won't be keeping your range of movement and your flexibility of your muscles and your tendons and your tissues.
Okay, with the final 5 minutes on the show, let's talk about craniosacral therapy. You also indicated that babies, you work on newborn babies,
yes,
2-week-old babies and above, but you've also suggested that it works well with colicky babies. So what exactly is this modality all about?
So cranial work, so the cranium is the skull and the sacrum is the tailbone. So we're working with all of the alignment of the cranial plates around which become or incorporate the skull, the alignment of the first vertebra of the skull on the first vertebra, the alignment of the entire vertebral column into the pelvis, the sacrum and the coccyx. So we work with the dural membrane around the spinal cord and the brain. We work with this, we can feel the cerebrospinal fluid movement up and down the spinal cord and the infoldings of the dural membrane into the different areas of the brain as well. So we incorporate, we're working on a bony level, on a membrane level and on a fluid level as well. So we're working with the whole nervous system. We're working with the alignment of the nervous system. If one cranial plate is severely compressed or off-center from, for example, a forceps delivery and the forceps slipped and you get severe rotation and movement of one of the temporal bones, which I've seen a few times in children, and that affects the alignment all the way down. It's going to affect their meeting their neurological milestones and those kind of things as well. But especially when the base of the cranium, right underneath here, you've got your vagus nerve. Now your vagus nerve is your rest and digest supply to your whole digestive system. And that opens your sphincters, increases your blood supply, promotes peristalsis, and helps the baby digest everything properly. If the neck has been severely traumatized or the cranium has been traumatized during the birth, it can be natural or cesarean or assisted with forceps, then that nerve is severely compressed. Then we find that the nervous system is functioning too much in your fight or flight, which is your sympathetic nervous system, or if the birth was quite traumatic, the child will also be still stuck in that sort of fight or flight activation, and that reduces the blood supply to the organs, shuts down the sphincters, and it doesn't promote peristalsis. So that's where we get the colicky babies.
And you would know this, or Mom would know this, because she has a baby that just doesn't settle down and is crying all the time. So you, as a craniospatial therapist, you would be able to you'd be able to examine the baby and pick up immediately what's wrong.
Yes, yes. So I've had one child, the mom thought that they were colicky because they were crying all the time, incessantly crying. There's also specific things that, we look at for colic. They were crying more than 3 times a day and they were incessantly crying and all of those things. But when I actually started to treat the child, I actually found that the one shoulder blade connecting to the shoulder was in such a strange position, and there was so much muscle spasm that it must have been pulled during the cesarean section to get the child out. So I actually started working then with what was a very mild brachial plexus injury and the alignment of the whole thoracic spine, and immediately the child calmed down, their digestion improved, they weren't crying all the time. So it's not always colic, but definitely seek support and seek advice if your child is incessantly crying, because there's normally something we can help to do about it.
I should imagine that's done through very, very gentle manipulation.
It's very gentle, and the child halfway through, they sort of, they were crying initially and they were a bit scared and thinking, who's this lady? And the mom was there and she was reassuring the child, and I started very gently starting to just mobilize, feeling what was happening, doing the cranial work, working with the tailbone, stretching out what happened higher up in the thoracic spine, working with the neck and working with the shoulder, and the child just settled down, they calmed down, they sort of started almost drifting into a bit of a sleep. And from that session on, we obviously did another maybe 2 or 3, depending on how much they needed. But then the child was like a different child, and the mother said, wow, this is amazing, you know.
And we've come to the end of the interview. It was fascinating. Hope to have you back again in studio. Thank you indeed.
Absolute pleasure. Thank you.
That was the lovely Justine Hunt. She is a physiotherapist and a craniosacral therapist as well. She's based in Johannesburg, and I'm sure that you'd be able to pick up her details on the web. Still to come, we're going to be looking at anxiety and depression with Dr. Colinda Linde, and lines will be open throughout that part of the interview as well. So we do hope you'll become a part of the conversation. Bismillah ar-Rahman ar-Rahim. Welcome back. And in this part of the show, we have Dr. Colinda Linde. She is a psychologist. She is in private practice, but she's also on the board of SADC. She does some amazing work there. So we're going to ask her to tell us about SADC, the organization. I think we need to know about them and other support structures around the country, like Childline, Lifeline, etc., because we're coming to silly season and people out of desperation really end up doing some crazy things, self-harm, and also possibly suicide. So organizations like Childline, Lifeline and SADC play a very, very important support structure in our society. Colinda Linde, Dr. Colinda Linde, good morning, welcome to the show.
Lovely to be here again.
Oh, lovely to have you here again. There's never enough time when we have guests with your profile on the show, because there's just so much to unpack, and of course we can't always do justice to the show and to the subject matter at hand. But I do hope we have a bit of extra time on the show this morning, so we do hope we can cover as much as possible. But let's start off by talking about your role at SADC, the importance that the organization plays in the community, and then we're going to talk anxiety and depression.
Okay, you know, I think it's wonderful to talk about something like SADC, which is an advocacy group. So the group was started about 24 years ago by Zane Wilson, and she was a panic sufferer, a businesswoman in Sandton who couldn't find any help. And when she eventually did find a psychiatrist and did do some CBT, she realized, well, you know, if I'm in this position and I can't find help, what about the rest of the country? You know, people who are not educated as such, about mental health, who don't have access to resources. So she marched into some of the pharmaceuticals, got funding, and the rest is history. So what SADC is, it's a group that provides advocacy. So, you know, for example, if we think about prescribed minimum benefits, you know, working with the medical aid so that they understand what they need to fund. Bipolar, depression, so those are all conditions now that the medical aids must pay for. They're called PMB conditions. And in the press, you know, the tragedy around S02. I'm being a bit controversial, aren't I? But,
no, not at all.
You know,
I mean, it's in our faces, yes. And it's really absolutely, it's something that should never have happened.
Yes.
And we realize just how much of pain and suffering it's causing to so many families around the country.
Right. And you see, this is where SADC, you know, we don't mean to be in conflict with anybody, but we stand for the rights of the patient. And mental health is so poorly understood. You know, there's so much stigma. So there's a lot of education that goes on, like this morning, you know, in the press. Whenever there's an issue, we get behind it. So it's all about how do we help people to actually get access to the treatments that they need. So there are support groups. There are a few hundred around the whole country. And we do talks at schools. We go out into rural areas, train the trainer. So people, if they want to look up, they can go to sadc.org, and everything is there.
And you could even volunteer to man the phones, go on a bit of training, and then become a volunteer counsellor on the phones. Just going back to S02, I must just say that my sister-in-law worked there, and I know at the time when they were moving the patients out, it was very, very traumatic time for all of them, all the healthcare professionals at the centre. And up to now, I know that they're going through a lot of pain because of what happened there. It should never have happened.
Yeah. You know, what you're talking about now is a very interesting topic, and it is part of the anxiety disorders. So post-traumatic stress disorder is, it's normally with reference to the person going through the trauma themselves. But what about the people on the outside who are relatively powerless? So that is vicarious trauma, where people are seeing negative things happening around them, but there's not much they can do. And they can also have post-traumatic stress after these things. So, it's a good point that you bring up. And this is just part of what SADAG does, that, when there's been a tragedy, the suicides that have been in the press recently, SADAG is often the first line. We're called in, we debrief the people who were around, when there's been a suicide, we'll go and do a talk. So
Can I
there's a
stop
lot of
you
that.
there, Dr. Kalinda? Let's talk about when you say debriefing. I always wonder and worry about that, because you come and you debrief me because I was exposed to something very traumatic. How many debriefing sessions do I have to go through to be okay again, if I can ever be okay? And is there some sort of cut-off point where it's, hey, this just ain't working for me? What would you then do in that situation? Let's assume I've had 3 debriefing sessions and I say to you, it's not going away. I can't get out of this dark hole, or the images keep replaying in my mind. I'm feeling helpless, I'm feeling hopeless. What's the next step then for me and any other patients in that situation?
Okay, so going to the debrief needs to be done correctly, and it's almost to order what has happened and try and make sense of it. So for a lot of people, around a third, the trauma symptoms with time will dissipate, the flashbacks will be less, there'll be less popping up at unexpected times, less thinking about it, and more normality. So that's around a third of people. And about 1 to 3 debriefs will normally be enough. So those are the fortunate ones. For another third, it goes on for several months. And then for the final third, they have proper post-traumatic stress disorder, where they're debilitated. They constantly have these symptoms similar to panic, where they can't breathe and they're reliving the trauma
Literally
and
freeze.
flashbacks. They can have that too. So a third, it's very severe. The research varies in terms of time frames, but normally you'd wait up to about 6 months. I know that seems like a very long time, but if you can see that there's a trend where the symptoms are improving, there's more normality, just the occasional symptom, if you have the patience and it's not interfering with your life, within about 6 months, you should be relatively okay. But if the symptoms are acute and they're not getting better, or in fact are getting worse, say 2 to 3 weeks after the trauma, you're still having all of that, then you do need to see a professional. And obviously not everyone can afford that. And that is where we have the helplines at SADAG. We've got trained counsellors every single day in the year, including all public holidays from 8 a.m. to 8 p.m. And they have a database of all sorts of therapists who specialise in trauma. But don't leave it if it's anything, even something in a medical sense. If you have any acute symptom that's getting rapidly worse, whatever it is, or if within 48 hours that symptom is still severe and it hasn't shifted, then you do need to seek medical help.
Okay. Dr. Kalinda Linde is a psychologist. She's in studio with us this morning. She is in private practice and she's also on the board of directors at SADAG. And if you have any questions or comments around depression, anxiety, whatever other mental illness that you'd like to discuss with her here on air, please feel free to call in. We have her here for about 40 minutes this morning. Bismillah and welcome back. We are talking anxiety and depression and a whole host of other mental conditions like post-traumatic stress disorder. We do have Dr. Kalinda Linde in studio with us. She is a psychologist, and of course, we're probably going to go all over the place with this discussion, but I think it's going to touch on some very important issues, and you can call in on the open lines. Now, before we get on to anxiety and depression, which really forms part of my next question, I had a discussion with someone a few days ago. She was in a terrible state. She was very, very emotional, cried a lot, and obviously I was talking to her about other issues, and I hit a nerve. And she broke down crying, and I wanted to know what was going on. And she then said to me she lost someone very dear to her 3 years ago. It turned out it was her fiancé. But she was really inconsolable 3 years later.
Okay.
I then suggested that she go for counseling because I felt that some work needed to be done with her. And she refused. She says, I've been for counseling before. A, it doesn't work. The pain is still very raw and very deep. And the counseling brings up way too much hurtful feelings for me. And when she said all of that to me, I felt it is really and truly a desperate need, and I truly believe she has to go in for counseling. I'm not the doctor, you are. What's your take on it?
Okay, this is a very big one, and I think we can cover a lot here. So there are different kinds of counseling. You get your person-centered, which is much more supportive, and often when a trauma has just happened, that's the best one. And a debrief can be similar to that. Then we get psychodynamic therapies, which are much more past-oriented, and they tend to focus more on the past and what's happened, and that could well be what she's been doing.
Why is she still in so much pain 3 years later?
You see, she hasn't moved through the bereavement fully by the sound of it.
The grieving process.
Yes, so initially when there's a trauma, there's shock, and after a while there's shock denial, then we move into bargaining, and this is a terrible thing. So she could be stuck there. So, we can be stuck in any of the stages. So bargaining is where we think, if only I had this, or I should have that, and there's a lot of guilt and blame. And when there's been a death or a trauma like that, where you can't do anything about it, you sit there with that awful feeling that if only I had somehow magically done X, this would have been different. If I had phoned him then, he wouldn't have been there, he wouldn't have died. That sort of thing. And that can go on for a long time, and that leads naturally to the emotion, which is anger and depression. So if somebody tends to keep things in and suppress, then that's depression. If somebody's a bit more, out there, they might become very reactive, just have anger outbursts, and eventually there's a bit of acceptance. But then it can all start again, back into denial. You wake up and you think, I'm sure this just hasn't happened. Oh no, it's happened. Then it's bargaining, anger, sadness, acceptance. And this cycle goes on.
But the refusal to go into therapy.
Well, you see, this cycle can go on for up to 2 years. The first year is rough with all the anniversaries and things, and then the cycle continues for another year. And after 2, the person should be more in acceptance than not. Now, if you're in the kind of therapy where you're talking through the trauma again and again, the tenet there is that if we keep talking about it, it'll go away. But I come from a place of cognitive behavior therapy, which is a bit different, where we meet you where you are now, and we look at normality as in what is still right with you. What parts of your life are still working? Where are you still functioning? Where are you still perhaps happy? And we look at you from here forward. Where would you like to be? And yes, I know some people will say, well, I don't want to move on. My life without this person is meaningless. And that could be a clinical depression that's set in. And at that point, you may need to look at some medication just to help the person chemically be more accessible for therapy. And if we were going to do cognitive behavior therapy, you would look at their habits, their behaviors. Are they getting out? Are they doing something functional? And you would also very much look at their thoughts. So the thoughts, when there's been a trauma, Viktor Frankl said this, many people have said this historically, that if you can find meaning in whatever trauma has happened, and that clicks for you, and you can actually see and acknowledge that, through that trauma, look at what I'm able to do, that will shift you. It gives you meaning. And of course, spirituality makes a massive difference if you have it. Mm-hmm. So all of those factors together, you can see that the way CBT or cognitive behavior therapy works is very practical. It gets you moving, and it's from here forward facing. We don't delve into the past. It's happened, and especially
but
after
not
3 years.
Talking about those feelings of hurt and the darkness and just feeling you can't go on without this person in your life. Are you able to, would CBT work for you?
Yes, it's a combination. We're not saying emotion doesn't matter, but if we were sitting here and we kept delving into the past and all the horrible things of the past, we could be depressed within a minute or two.
True.
Because it was painful then, it's painful now. But it's like a wound, that if you've had a wound and you keep opening that dressing and fiddling with that wound, it's not going to heal. So you're aware the wound is there. And we would in fact teach techniques. In fact, one of my new ventures this year is I've paired up with a coach who's particularly good at mindfulness and mastery. And we present mindfulness courses which are designed exactly for this. And the current thinking in CBT, the latest cutting edge CBT, brings this in. So people can have a look at practicalmindfulness.co.za. There's a lot of free information on there. So the mindfulness teaches you how to surf that emotion and surf through it as opposed to being tumbled all over the place by it. So that would be how you deal with the emotional side. Then the talking side would not be rehashing the trauma. It would be maybe once or twice talking it through, and then it would be, for example, I don't know this girl, but it would be something like, if your fiancé were here now, how would he feel about the fact that you're saying, I can't go on, my life is over? If it were the other way around and you were the one who had died and he were here now in this awful state, how would that be for you? Would you want him to move on? And probably the answer is always yes. And would he feel terribly guilty that his death had led to this? Yes. And if say she had done anything meaningful after that, helped people through her trauma, you could say, well, if your fiancé were watching that now, would he be really proud of you? And would he be thinking, wow, that's the courage I fell in love with? So can you see what I'm doing? That you're getting the person in touch with the parts of them that are still intact, and that can actually try to help them move forward into living again.
Would you
That's
apply
a
the
taste.
same? Would you apply the same principles to someone who comes to you and says, "I've lost my partner," and the feeling is so raw, it hurts so much. It's been 2 years, it's been 3 years, or even more, but it is physically draining me. I just can't get past this. Would you still use CBT and mindfulness with them?
I would typically, if the symptoms have gone on for more than 2 years and they're still quite acute, I would always bring in something biological as well. And this is where I work quite closely with the psychiatrists and the GPs. All of our brains have different chemistry and we have different levels of support. So, if say you're pretty much alone and isolated, you're going to probably need something like an antidepressant, or definitely the meditation, mindfulness, something spiritual. You need a combination. CBT will bring the person in touch with what's happening and also support, that they need support, like SADAG or something in the community. So that's where that would come in initially, and then start working with their thoughts and their patterns. But if they're really physically in
Really
pain
stuck.
and they're emotionally stuck, that the brain chemistry has altered to such an extent that they can't be accessible or the therapy won't stick. And that is when it's ethical to actually bring in something along the medication route. But I would sit with the person and explain it, because at the end of the day, it's a person who's going through the trauma, but they often become the trauma. They forget that they're a person. They were a person before. So my job is to look at them holistically, sort out the brain chemistry on a biological level, get your support in, get the therapy in, bring some spirituality in, so you can actually start getting back into your life.
But you don't want them to become hooked on the medication.
No.
There's that risk as well.
Yes. You see, you're quite right that people who, and again, I don't want to disparage GPs because they've got a difficult job. 15 minutes, they've got to do all of it. My job, the financial advisor's job, and the medical, So sometimes they will hand over tranquilizers because of empathy. The person will feel better. But after 4 weeks of tranquilizers, you're often hooked. So we'd be looking more at antidepressants. And if you can get to a psychiatrist, that's always first prize. There are not many of them. Or ideally a GP who is a bit more trained in mental health. And antidepressants are not addictive. And there are all sorts of new things on the market where in tiny doses they can be used for anxiety, but they're not addictive. So you're quite right. You don't want to have the problem of the trauma and now
Absolutely.
you're addicted to something.
Okay, let's go for our next ad break. When we come back, we're definitely going to touch on anxiety and depression. Dr. Kalinda Linder is our guest. She is a psychologist. She's also on the board of SADC, and we are here talking mental health issues. And of course, if you want to become part of the conversation, do call us on the open line. Not Thank you for staying with us. We're into the final segment of the show this morning. We're talking to Dr. Kalinda Linder. We're talking mental health awareness. We did say that we're going to be talking anxiety and depression. And I know we've touched on other issues around mental health, but they're all interconnected. And I'm glad we touched on those because it gives a bit of background to what we're going to talk about right now. And that, of course, is the different forms of anxiety and how that eventually leads on to depression or can coexist. Both the conditions can coexist with each other. Would I be correct in saying that, Kalinda?
That's quite right. You know, if you look at the medical sign with the snakes going around the sword.
Yes, the serpents.
Yes. So if you think of one being anxiety and one being depression, it often works like this. There's about a 70% overlap. So say if you treat a depression and anxiety often pops out, then you treat the anxiety and the depression often pops out. So if you have chronic anxiety, like say generalized anxiety, or we've mentioned post-traumatic stress or a severe phobia, that sort of thing, there's a very good chance that that will eventually become depression. Because depression comes from when you're trapped in a situation and you can't get out. So that chronic anxiety is exhausting.
All right. When we talk about anxiety, what are we talking about? Constant worry, constant fear, constant obsession about a fearful situation in your life that you can't control?
Well, you know, that is a very big topic, but I'm going to run through them quickly. So you get a family of anxiety disorders. So the one that you've touched on is generalized anxiety. That's the most common. And that is where the key feature is worry. And if you haven't got anything to worry about, you worry about that.
Oh, my word.
Look, we all worry, but it becomes debilitating. So that is the most common one. And with that comes a hyperarousal. You feel just, you know, hyper alert the whole time, looking for threat. That's a very brief description. If people want to read more about this, I've created a free site. Everything is free.
Oh, wow.
It's called thoughtsfirst.com because your thoughts come first. And there's a document on there called worry. And there's a CBT technique for worry on there. And a big discussion around generalized anxiety in that document. So that covers that. Then we get panic, which is much more acute. It's a sudden onset of these really frightening symptoms. And you feel you can't breathe, your heart's going crazy, you have no idea why it's happened. It lasts for a few minutes, maybe up to an hour, and then it's gone. And you can't understand why that happened. And then you get into a fear of fear cycle. When's it going to happen again? And that becomes panic disorder. So that tends to be because of a build-up of a lot of things, like a pot's too hot and it boils over, but you didn't feel the build-up, and then suddenly this panic comes. So that is panic disorder, and there is something on the site about that as well. And on SADC's homepage, there are a few podcasts on panic, what it is, why it's there. So, you know, there's a lot of that information available.
Now, can I just ask you this? We've touched on a whole host of issues. We talked about anxiety, panic disorder. We talked about deep grief, etc., and you just can't get over all of these things. What about the state of mind? What about, you spoke about CBT and mindfulness. Would that be the answer? Could you start, you know, positive self-talk? Does that help? Can that help you going a certain way and overcoming all of these conditions, or some of them?
You know, that's a very good point, because all of these conditions have got thoughts, behaviors, and feelings in the body as well as emotionally. And what the latest research is showing, I'd say the last 10 years, but especially the last 2, is that all 3 of those need to be worked on. So I find often the behavioral...
Can you just hold that thought, please? Let's take a call. Assalamu alaikum to our caller. Welcome to the show. Caller, you're on air. Please go ahead. Caller? Hello?
No? What is
Yes, yes, you're on air. Please go ahead.
it? Assalamu alaikum.
Walaikum salam.
No, man.
You are on air. We can hear you. What's your question? Caller? Okay, let's go for our next ad break. Maybe we can see if we can connect up with a caller. We'll take that call and then we'll start wrapping up. Welcome back, and we've just got about 3 minutes to wrap up time. We still have a call online. We haven't even touched on depression. We wanted to touch on suicide as well, but what I think we'll do is get Dr. Linda in again, possibly towards the end of this month. But we do have a caller. Let's see if we can help the caller. Assalamu alaikum, welcome to the show. Caller, are you there? Okay, let's, we obviously have problems at the line. We do apologize. Kalinda, let's wrap up. We've touched on a lot of little different things as far as mental health is concerned. You definitely have to come in again to talk about suicide and other issues. Let me give you these last 2 minutes to summarize and wrap up on what we've talked about this morning.
Okay, so first of all, nobody chooses to be anxious or depressed, so they can't just snap out of it. That's something really important to get across. And just like anything else, it can be treated. So if you were diabetic or you had an ulcer, you would have a combination of lifestyle change, therapy perhaps to deal with it, the stress of it, and then definitely medication. So in the same way, anxiety and depression respond very well to a combination of these things. And the research also shows that support is really important. So this is where shows like these, where you give education and support, information, your community, and places like SADC.
And support from your loved ones.
Yes.
Obviously, because if they become impatient with you, it probably just pushes you deeper into the dark hole. Unfortunately, we have come to the end of the show, but we definitely have to get you back in again to pick up from where we left off, because we've just scratched the surface. So that's it from Dr. Linda. I am sorry that we've got to wrap up, but we have run out of time. She will be coming in towards the end of the month, and we promise we'll pick up from where we've left off. Thank you for being a part of this conversation. We've loved being with you till Wednesday morning at the same time. As always, please take care on the roads. And a big thank you to the production team. And from me, Julie Alli, as always, it is Khuda Hafiz.
يا هلا 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 حن قلبي على جمعة الخير هلا حن قلبي على جمعة الخير هلا يا هلا ويا هلا ويا هلا ويا هلا يا هلا ويا هلا ويا هلا ويا هلا ويا